Hello, this brief describes the cost of extended hospital stays when patients no longer need a hospital level of care but cannot live independently and also do not have access to go to a nursing home. Where I'm going to be taking you today is really two reforms that are necessary, and the first is reforms to nursing homes or skilled nursing facilities, and the second for reforms to the Medicaid spend-down program. And really, the reforms to nursing homes is that nursing homes should be required to respond to referrals sent by hospitals and other providers within 2 business days, so in a timely manner. And also that nursing homes should not be able to reject a referral due to lack of insurance. For Medicaid spend-down reforms, really there should be 2 more categories of items that are considered non-countable assets. The first being farmland, and the second being business ownership valued up to a limit. Similar to the way a primary home is considered a non-countable asset up to a certain limit in value. And in order to explain why these are important, let's first start with a patient example. So, John is a 70-year-old widower. He owns a small business making and selling maple syrup from trees on his property. His children have been running and expanding the business for the last several years. His children are currently busy running the business, tending to their own families, and can't give him the 24/7 care that he needs. He has recently suffered a stroke, and so cannot consistently care for himself. He needs supervision. He has Medicare because he's over the age of 65. He does not have Medicaid, and in order to qualify for Medicaid, he would need to spend down his assets. And his assets are his farmland and his business, the equipment with his associated with his maple syrup business. His assets would also include his home if he can no longer live there. Furthermore, he cannot transfer his assets, his business and his farmland, to his children at this point because the Medicaid spend-down rules include gifted property and countable assets within the last 5 years. He would not be able to give it away. He would not be able to sell it to them for significantly less than it's worth. So, what happens next to John? Well, in our example, John would remain in the hospital after his stroke. Referrals would be sent to nursing homes and to skilled nursing facilities, subacute rehabs, and the such, and they would reject him due to a lack of payment source. Many of the nursing homes probably would not even respond to the referral. And so, at least in New York, a hospital cannot discharge a patient without a safe discharge plan. John has no safe plan because his family says they cannot give him the supervision he needs, and there is not another facility willing to accept him to give the supervision he needs, and so he cannot be discharged. His insurance company is under no obligation to pay for the extended hospital stay beyond what was necessary when he needed acute care, and so the hospital must raise prices on all other patients to pay for this type of patient. It increases costs to everyone. It broadly increases cost. Eventually, John may recover enough to go home, or he may stay in the hospital until either his children have a change of heart and take him home, or he dies there. Sometimes patients end up in the hospital in this kind of situation for extremely long periods of time. And why is it bad that people remain in the hospital so long? In this chart is the approximate cost per day to take care of a patient in various settings. As you can see, the cost per day for a hospital stay, this is not an intensive care unit. This is a floor bed, recovery bed, medical surgical unit. It is 4 times higher than having higher cost than having 24/7 home aides in the home, and 8 times higher than cost of being in a nursing home. It's these extra costs that are costing our healthcare system between $500 million and $1.5 billion annually. That's billion with a B. Estimates vary because there isn't good published data on how frequent and how long these patients are staying. But the question then becomes, what should we do about this? It's expensive. It's poor health care for the individual involved. And so, the first part of the proposed reform, is better, safe discharge planning. And really, the key point here is reform of the way skilled nursing facilities and nursing homes respond to referrals. First, we need to make it easier for a hospital to present a safe discharge plan to the patient. We can do this by passing a law requiring skilled nursing facilities that accept Medicaid to respond to referrals within 2 business days of receiving it, and furthermore requiring that they not decline patients based upon a lack of payment source or any other status protected by law. Similar to the way the EMTALA law works for hospitals, in that hospitals that accept Medicare and Medicaid patients and the reimbursement from them cannot turn people away from the emergency room regardless of ability to pay. The second aspect here is disallowing nursing homes from rejecting people for the lack of ability to pay. Nursing homes would still be able to charge patients. I'm not saying that they should accept all, regardless, that they should allow people to stay there who are not paying. And I would even say that nursing homes should be allowed to evict patients that do not or cannot pay their bill there. But still, requiring the nursing home to accept the referral allows the hospital to have a safe discharge plan, and a hospital with a safe discharge plan can issue a notice of financial responsibility and begin billing the patient unless they either accept that plan or leave the hospital AMA, that's against medical advice. Now, if we passed this alone, that would put patients and their families in impossible situations where they are given a plan they cannot afford or to leave and be in an unsafe situation. And so in order to assist them with a second part of the needed reform is as follows. Exemptions to the Medicaid spend down. This would fairly allow middle-class individuals to receive the level of care they need. They would need Medicaid in addition to their Medicare, and as I said, Medicaid currently requires spend down of countable assets. Current exemptions to the spend down rules are 1 vehicle, a home if still lived in by the recipient of Medicaid or spouse. Some states set a limit on house value as well. Prepaid funeral expenses, personal items, family heirlooms. They are already considered non-countable assets. So this proposed reform is to add 2 more categories to non-countable assets. The first, farmland. Farms generally run in the hundreds of acres, which would carry a market value in the millions of dollars. And so it's important that those be non-countable so that they can be passed on to children and inheritors and stay an active farm. The second would be business ownership with a likely cap of $1 million. Many small businesses and farms have equipment in addition to their land, capital worth close to that amount. So those are my proposed reforms. Thank you very much, and if you have any questions about this policy brief, more information is available in the full proposal. Thank you for your time. References.